Hello, everyone. My name is Dr. John Allison, and today we're going to talk about stroke prevention and atrial fibrillation. So, as a brief introduction, I am a cardiac electrophysiologist in Austin, Texas. So, a cardiac electrophysiologist, or EP, is a heart rhythm doctor. So, I specialize in the prevention, diagnosis, and treatment of heart rhythm disorders, and that can include atrial fibrillation or Afib. Today, we're going to talk about stroke prevention and Afib. At our last talk, we talked briefly about what Afib is and what it means to have Afib. I think that before we go into stroke prevention, we should briefly touch on what Afib is and why it causes strokes. So, Afib is the most common heart rhythm disorder in the United States. The heart has four chambers, two in the top and two in the bottom. The top chambers are the atrium and the bottom chambers are the ventricles. Normally, a heartbeat starts in the top chamber where you get a good squeeze. The signal travels down to the bottom chamber and it squeezes. So you get this very nice organized rhythm like this. In atrial fibrillation, the top chambers, the atrium, are fibrillating. They're doing this. It's a very disorganized rhythm, which causes the bottom chambers to be very irregular. And it's that very irregular beating of the bottom chambers that we feel as atrial fibrillation. Next, we should talk about what is a stroke. So in general, a stroke is just loss of blood flow to the brain. And this can be due to a couple of different reasons. One, it could be a blockage in one of the blood vessels around the brain. This could be due to a blood clot, like an Afib, or it could be due to plaque causing plaque blockage from either the neck or arteries or vessels around the brain. But it could also be due to bleeding around the brain. Bleeding can occur because of a fall or a ruptured blood vessel like an aneurysm. Why is stroke prevention important in Afib? So Afib is the most common heart rhythm disorder in the United States. It affects about 5 to 10% of Americans, and that number is rapidly growing. And Afib is the leading cause of stroke. About 20% of all strokes are caused by Afib. Afib can be symptomatic or have very mild symptoms. And then for that reason, a new stroke is often how Afib is diagnosed. So how does Afib lead to strokes? So the top chamber of the heart, the atrium, especially the left atrium, has this pouch called the left atrial appendage. When the heart is fibrillating, when the top chambers are fibrillating, without that good organized squeeze, blood can pool in that pouch because it's not squeezing. When that blood pools, it causes a blood clot, and that blood clot can eventually break off, go to the brain, and cause a stroke. Your risk of stroke in Afib is proportional to what we would call a stroke risk score, or more specifically, a CHADS-2 VASC score. You can see it. You can calculate your own CHADS VASC score at this website, mdcalc.com. Essentially, you can get 0 to 9 points based on the number of stroke risk factors you have, your gender, your age, all sorts of cardiovascular conditions you may have, whether you've had a prior stroke before. And that will tell you whether your stroke risk is between about 0.5 to up to 12% per year. Who benefits from stroke prevention? Generally, people who have a stroke risk score or CHADS-2 VASC score greater than or equal to 2 points would benefit from stroke prevention as long as the benefits of that stroke prevention do not outweigh the risks, such as recurrent bleeding or inability to take blood thinners, which we'll talk about in a second. So how do we prevent strokes in Afib? And the first thing we should talk about is that by preventing strokes, we're not actually affecting the heart rhythm itself. The treatment of the heart rhythm is a completely separate topic. For stroke prevention, these medicines and treatments are just to reduce the stroke risk. So there's two ways. There's medicines and then there's procedures. The first thing we'll talk about is medicines. These are blood thinners or anticoagulants. And there's two classes. There's warfarin or Coumadin. This is the original blood thinner that we had. It came out a long time ago. These days, it's rarely used because of the newer agents that are available. It's cheap, but it does require regular monitoring of levels, and it has significant interaction with diet and medications. Additionally, it's also the only choice of blood thinner if you have a mechanical heart valve. The more common blood thinners that we use are direct oral anticoagulants, or DOACs, and there's essentially 3 that are widely used in the United States. There's apixaban or Eliquis, Xarelto or rivaroxaban, or dabigatran or Pradaxa. These medicines are preferred because they're easy to take. They don't need to be monitored. They have very little to no interactions with diet and medicines. And however, they can be expensive, but they cannot be used in people with mechanical heart valves. Additionally, compared to Coumadin, there is a pretty widely accepted better safety profile for them, meaning they result in less bleeding, such as bleeding in the brain or bleeding in the GI tract. Another potential option for stroke prevention is exclusion of the left atrial appendage, that pouch. If we can get rid of it or remove it from the equation, then we can reduce stroke risk that way. Who qualifies for exclusion of the left atrial appendage? So these are people who would benefit from stroke prevention, so their CHA2DS2-VASc score is greater than 2 or 3, and they're intolerant of blood thinners due to other medical conditions or lifestyle. So they might have a history of falls, they have recurrent GI bleeding, anemia, or low blood counts that cannot be fixed, or they have, like I said, a lifestyle that doesn't tolerate blood thinners. Perhaps they're a lumberjack or a professional downhill skier. These are usually implanted by cardiologists and electrophysiologists like myself. One of the options for left atrial appendage exclusion are these plugs. There are 2 available. One is Watchman, made by Boston Scientific. The other is called Amulet. It's made by a company called Abbott. So these are percutaneous devices, meaning they're delivered through the blood vessel of the leg, taken up into the heart, deployed into that pouch or the appendage, and then the delivery system is removed and the plug remains to seal off that pouch. It'll stay there permanently until eventually the plug tissue grows over it and it becomes a part of the heart. The idea is to seal off that pouch so that blood clots can't form in it and break off and go to the brain. This is about a 1-hour procedure. It is done with general anesthesia. It does typically require 1 night for observation. It is a minimally invasive procedure, but it does not mean it comes without risks, although the risks are relatively minor. The most common complication is bleeding from the leg, but we'll usually use a closure device or plug under the skin to seal off that hole, and the risk of bleeding is relatively low. Causing a stroke is a potential risk of the procedure, as well as poking a hole in the heart or the device being dislodged or coming out. Occasionally, the seal of the device is not perfect and isn't detected until later. So a persistent leak around that device, which can still be a stroke risk, may require longer-term blood thinners, or might require a second procedure to close that leak. Depending on the device, blood thinners may be recommended for 6 weeks after the procedure until the device seals over. And then an extra imaging study, what's called a transesophageal echocardiogram, or an ultrasound that's done through the mouth to look at the heart, will be done to check the seal and location of the device to make sure that everything looks good. Another potential option for exclusion of the left atrial appendage is surgery. This can be done with either clips or amputation of the pouch. This is usually for people who are undergoing open heart surgery for other reasons. They either need a bypass surgery or a valve replacement. However, if the shape of the appendage is not appropriate for one of the plug devices, then a clip can be delivered through a small incision in the chest, but it is still done by a surgeon and still does require access to the chest wall through a surgical procedure. And this is, like I said, this is done by a cardiac surgeon. This is a brief overview of stroke prevention and AFib and how we prevent strokes. Here's my contact information if you have any questions. I want to thank everyone for attending this discussion about stroke prevention. Once again, my name is Dr. John Allison. I welcome any questions. Please submit them through the Cardiovisual Instagram page, and we will try to answer them.